because there's three of us, we're going to probably be tough on time. So I'll try to move through this as reasonably as I can. Again, I'm honored to have my friends with me. I think for those of you who have watched me all the time, I think you know I'm always talking about the importance of the team concept, right? The clinical partners that we work with. And also for me, I'm kind of honored. It's special for me because I only work with about 12 different clinicians around the world, and every one of them is pretty much a friend at this point in my life. Otherwise, I probably wouldn't want to work with them, to be honest with you. So I have great relationships, and it's nice to have that kind of a contrast, that it's not just about work, it's about family and friends too. So nice to have both of you guys here today. So thank you for jumping in. And by the way, I just threw this at them basically last night. So let me show you how this ties together for me. So when we talk about denture, whether it's digital or analog, everything really starts the same. And for those of you who've seen most of my presentations before, and I'm sure there's people out there who have, everything really starts the same for me. And that is, aesthetically, where do teeth belong? And I think we kind of miss the gate sometimes when we start talking about it's going to be a denture, it's going to be implant, it's going to be this, it's going to be that. For us, and my team is kind of on the same path with me, it's all the same process. Where do the teeth belong in that human's face? And once we kind of make that determination, that incisal edge position, or that IEP that we talk about, really helps determine almost everything else, where the gingival tissue will be, angulations of teeth if we need to alter something or rotate something. And it just feeds into a starting point for everything that we're going to do. And it kind of blocks out what the challenges will be, meaning that, well, this will be implants, this will be just PMMA materials, this will be veneers. We're kind of cutting through that and getting right to the point where we're saying, where do we want our teeth to be? And to do that, it's denture. And this is where it's kind of funny to me, because denture premise is kind of the key to everything aesthetic and functional. And for some reason, I know when people see me, they think of me as ceramics guy and everything's about putting mamelons on something, but it's not. It's really about managing the entire patient from a health perspective, a functional perspective, and an aesthetic perspective. So when I think denture, what am I really thinking about? First and most important is the IEP, the incisal edge position. Where does it belong on the face? Where does it belong in that patient's face to make it look good? And once I've determined that, then it starts to give me not only the gingival architecture, because I know the average central is 9.5 to 10.5 millimeters. Now I have an understanding of where I want my pink to be, and then it also gives me a horizontal plane. And those two steps are kind of Bible for me, and I think for all three of us, right? That's where we're kind of looking at everything. Now, when I say it that way, I think sometimes people get a little confused, because I feel like it goes right away to, well, functionally, where are we going to be and what are we going to do? And we're kind of cutting through that, right? We're kind of saying we're not thinking of the function because we're thinking of the aesthetic parameters first. Once we've determined the aesthetic parameters, now we're going to come back and we're going to bring in step 3s and step 4. And that's going to be, what is the OVD? Where is the lower incisal edge position? And then what is the balanced occlusion that we're looking to set up on the lower? There probably are times, and I think when we've done cases over the years, there are probably times where we have the perfect IEP, but when we get involved with the patient, maybe we can't keep it where we like it to be based on the functionality or the lack of more restorative, right? So there is a little bit of a conflict there. But I think, and I think you guys would agree, that realistically, 99% of the time, once we get our IEP, we're kind of working from there, right?
Mm-hmm. Yep.
Okay, so now the next question becomes about space. How much space are we working with? Are we working with long teeth or short teeth? And is it going to be white involved only, or white and pink? So we have to start thinking through the processes about where do we want the teeth to be, but also does it give us what we need? And it's funny because Dr. Castellano and I had a great conversation in the car ride over here last night, and on the plane, actually. I think we annoyed the whole plane, by the way, with our dental talk, because both of us talk loud.
Yeah.
And we were probably screaming on the flight for about 2 straight hours about when there is pink involved, when, where, and why, and how it affects the restorative option. And again, I don't want to go down that rabbit hole too much. I was right at the end. No, I think we were both had really valid points, and it was a great discussion for us to educate ourselves in the differences of how we see it. And I think it was it actually started from an MK1 case, right?
Yeah.
Where we talked about how much pink we need. And you'll kind of get to see that in the case I'm going to show now. But the point of it is, boy, those conversations are probably some of the most valuable learning in dentistry, right? Just having that one-on-one and going through how we're thinking about it and what we're seeing and what we're trying to accomplish when we're adding white in or pink into the restorative process that we're doing. So it was a great conversation. We classify these usually by a prosthodontic fixed partial denture, FP1, FP2, and FP3. And I don't want to overcomplicate it. I'll just say the simplicity of this is anytime we're dealing with FP1, you're dealing with only white. When you're dealing with FP2, you're dealing with white, and possibly you might need some pink. And when you're dealing with FP3, you need pink. So it's just a simple way to classify which direction we're going. And you don't have to be technical with it, but it's just kind of a nice, on the phone it's FP3, and now we all know where we're going right away. So just a way for us to think it through as we go through the process. And this is where our conversation went last night, was a lot about how much space you have. So when we're doing full denture or implant restorative all on X-type cases, part of the challenge really becomes is where is the bone level that we're starting with? And is that in the aesthetic zone? And we know that we need about 16 to 19 millimeters on the maxillary arch to make that work. Problem is we have a lip dynamic, and we don't know if that lip dynamic is going to be fruitful for us to hide our transition, or it's going to be challenging for us. So that was our big kind of part of the conversation last night. And because of that, we put in some lip dynamic slides. So there were 3 basic, and you guys can add into this if you want. I'm kind of running through it quick to move us through in time, but there are 3 basic types of lip dynamics, right? So we have VME, which is where people really show a lot of white and pink. And I think over the years, I've always used the same joke and said, when you see these patients, run for the hills, right? Because these are your biggest nightmare patients, only because it's hard enough to make the white blend and look perfect. It's even harder when their pink is exposed so much because of the light and the interaction. Good news was that was about 15% of our population. The second that you see on your screen is brachiofacial, and that's kind of more me, where you don't really see much of my teeth. And these are your favorite patients, right? Because those are the ones you put the single central in and they go, looks great, doc, right? And they leave and you feel very comfortable. And then the average person that we have is about mesiofacial, which is about 70%. But, and this is part of our conversation too last night, that's not really the case anymore, right? I mean, the world has changed, and now we're at the point where, what's the proper way to say it? Lip augmentation?
Plastic surgery.
Yeah. I mean, the bottom line is it's Botox and Restylane, right? But I mean, it's fillers. It's probably a nicer way we're supposed to say it to be politically correct today. But what's really happened is this concept has changed. And now it doesn't mean that we're changing our restorative process, but what it does mean is we have to look at it differently, right? I think you said you had a patient recently that when they came in and you went to either take pictures or look at them, you couldn't even get a cotton roll around the mouth, right? And that's a challenge.
Yeah, there's no vestibule anymore. And we did that case, we did 20 veneers, and it's kind of hard to deliver them when you can't, retract them.
It's frustrating.
It's a challenge.
I know I did a case years ago, and I won't go through the whole story, but I can just tell you it was a full mouth rehab, and I was shooting it for a lecture in Chicago. And when the patient came in after 6 months of work, and she came in a week or 2 before Chicago, and not joking, I said, smile. And she looked at me exactly the same. I'm like, smile. And I couldn't even get retractors. I mean, it was so, and again, we're not making fun of people. We're just saying there's a challenge to how we look at it now, right? It changes the game of what we're doing because there are things that are affecting it. So we still want the same thing. We still want to know where the incisal edge position. We still want to know how much papilla should be displayed or not. But it is now affected by the alterations that people are making, and it does make it more challenging for us. So as a standard, on 100% of a tooth, whether that's 10 millimeters or whatever the number is, usually about 35 to 40% of that would be pink. And again, we're not going to let the fillers influence us, right? We're going to still do the right thing to put the teeth and the pink where that really needs to be. And the same with the contacts and embrasure spaces and everything that we're trying to do in nature, we're going to stick to the plan, even though the filler may alter or the lip dynamic may alter what we're seeing as we're working through the case. So let's start with a denture case. And this is a great case because it started in a place where, we all look at it and say, where do you want the incisal edge? Well, I don't even know if there's a great reference here, right? Because we're kind of lost of looking at the case. There's a case I did actually with Dr. Bernadette Sava. And in this particular case, we were a little confused. Normally it's easy for us to look and say, I like this. But when you have one tooth in the center of the face that's probably too long, it throws off your perspective. The other thing that I saw that I thought was interesting was the collapse of the lip, especially more on his right side, but you can see that it's not supported as well as we would like it. So we did all the normal things, right? We tried to figure out where we like our incisal edge position, horizontal plane. Then we talked about OVD and all the things that we would normally go through in a denture setup. By the way, we weren't sure if it was going to be a denture. We kind of thought it through, and we know he's going to have implants because he didn't have many teeth left. But the end goal was we had to not only think about the white, we had to also think about the pink. And no, we didn't make those. It's always easy to look back on people's work and think, oh man, how is that patient walking around like that? So in the end, this became an all-on case, upper and lower. There were 4 implants on the upper, 4 implants on the lower. We went through our normal procedure, right? Preliminary impression, an IVJ, custom impression to capture all the positioning. And then from there, we had to decide, is this going to be a white and pink case? And that's where it became a little confusing to us because in some ways it kind of looked like it could be a white case. I really kind of thought, and I think Dr. Bernadette and I felt the same way. We were like, maybe this could just be white and we could stick straight crown and bridge and not overcomplicate it. So we did a setup of all white. I waxed the case up. I made all white teeth, put it in the mouth and filled the space. And although we liked the incisal edge position, I still felt like he didn't have the support in the face that he needed. And this can become hygienic of an issue, right? Without having, a lot of food and saliva slipping through here. So it kind of led us to go back and say, we got an incisal edge position, but now we really need to figure out that this is going to be an all-on type case. So we decided to make this as a Toronto bridge. We did our setup. We did a titanium bar underneath that for design and support, which I'm a big fan of, by the way. And then we turned that into a straight denture case, just white and pink acrylic, set it up and place it in the patient's mouth. And what's interesting is at the end, and you can also notice here a little more of the support on his lip. What's interesting at the end is it's hygienic. It is retrievable by clinical side, but for the little tiny bit of pink that he shows, how important would it have been to not have that, right? Like what we wanted to do and what we had to do is kind of 2 different things. And I think back to your point.
What you could get away with,
right?
And what you decided to do.
Could we have left it all white?
Sure.
I guess we kind of could have. Could I have done it in crown and bridge and used pink ceramic? I could have. But in the end, my next thought is now from a hygienical point of view. How do I manage that back into the tissue, keep it cleansable and flossable? So that was really kind of the key that drove us here. And that was kind of back to your point. He has a low lip dynamic, or he has a normal lip dynamic, I should say. But even with a normal lip dynamic, we were able to make a marginal integration or intaglio surface from our pink to pink and still keep it cleansable and hygienic. And then we just really adding the pink for support of the lip and to fill the spaces the proper way. So in the end, it worked out well. I think most of you guys know from watching a lot of the ceramic lectures, I'm a big fan of fluorescence and things in ceramics. The good news about a lot of the denture teeth today, especially the old school denture teeth, the analog, is they're built with fluorescence in them. I don't know if you guys have ever seen this picture, but this is actually cool because if you go back to what I do in crown and bridge, I'm always trying to incorporate that fluorescent into it. And when you get into denture teeth, it's really almost amazing because I didn't know that this existed until I just coincidentally took a photo just to see. Look at how they've built the fluorescence into the denture teeth very similar to what nature has. So that's really cool. And I was kind of excited to see that. And it kind of made me think more about the teeth and the process of what I'm doing and why I'm using it. I think you also know I do tweak the teeth a lot of times. So when I am doing dentures like something like this and I want to kind of characterize it more, this is an MK1 case, which spurred on our conversation. When I'm working on these kind of cases, you want to make them a little bit more fitting of the patient, 90-something-year-old woman, and you wanted to get a little more color out of the pink and a little more color and staining out of the teeth. In truth, I probably could have even flattened some of the edges and made them a little more aggressive, but it worked. So we're just using a little bit of the stain for that, which is a great system to add in to it. And all this is done analog. So I don't want to confuse people and make you think that this was digital, although part of this can be done digital. And I think you said it before, which is a great line. Almost everything digital turns analog at some point anyway, right? And I kind of live by that. So I want to be clear with everybody. I've milled a few digital dentures. I don't have any intraoral at this point. I'm still playing with the material and working with it and getting comfortable. I'm not really a denture lab, so I tend to do more crown and bridge, and most of my denture setups are implant involved.
So this is Angela. Angela came to me, a patient of the practice, with some composite bonding on her front 4 teeth, and she wanted to change the look because she didn't like that they were kind of blotchy, the teeth all kind of matched, and she wanted to get ready for her sister's wedding. So like with what we've been talking about, we're thinking denture. Where does the tooth belong in the face? So to kind of show this, we do reference glasses on the right. These are the Cois reference glasses. But frankly, for me and Peter, I think just a really good natural head position photo with retracted teeth apart is going to tell us exactly where the teeth belong, with whether we're using eye plane, horizontal plane, some sort of horizontal plane of reference. Some people's eyes are a little messed up if we use a regular ear bow with a face bow.
We don't tell them they're messed up, though. We just say
may not be, but we want some sort of horizontal plane.
Of course.
And the reason for this is just for camp purposes, right, Peter?
Yeah, I think that the Cois glasses are a useful tool, especially when you're teaching to get the head straight. But I think at this point, we do it every day, and it's not really something that we utilize, but I get it.
Mm-hmm. So if we look a little more closely, what we see is maybe she falls in that 10-15% with vertical maxillary excess, and she declined crown lengthening. So we're already kind of limited by what we can do in this case, and we don't really want to bring those teeth down to 10-millimeter length because then they're going to hit her lower lip while she's smiling. So as far as incisal edge, we're probably keeping it about where we are.
So this becomes an aesthetic change, and our reference point is what she has. That's our new IEP, just like if we're setting her up.
Yep. So me as a clinician, maybe I can prep a little more subgingivally, and Peter can kind of push on that gum a little bit with his porcelain, but the case is essentially going to be front 4 veneers because she can't afford to do any more. You'll notice in this occlusal shot, this is just part of my diagnostic records, there is some erosion on those teeth that is all from a celiac disease diagnosis that was discovered a little too late. So we're well aware of this. Kind of moving forward, this would be my first appointment that I'm documenting the prep appointment. So before numbness goes in aesthetic, we're getting the rest of the teeth. So we're doing our shade communication with Peter, and we use the VITA 3D linear shade guide, which is excellent, and we're giving him a reference point.
And if you don't mind me jumping in, two great points that you have here in these 2 photos. Notice the teeth that he's taking the shades of, not the ones she doesn't like. So he's got shade tabs by the cuspid, which is a natural tooth, and it's a nice looking tooth. And then he's giving me the lower incisal to show me the lower incisal's color, or the lowers, the 2 centrals. So I have a reference of how to improve what's happening here. A lot of times I'll see people take pictures, next to the 8 and 9, and I'm like, well, we don't like those. So that's not really a reference for us anymore.
Another good technique, what Dr. Amendolia said, this is the first thing he does. And sometimes, people will take shades after they've prepped or actually anesthetized and start doing work in the mouth, and teeth become dehydrated. So it's important to get an accurate color by doing it first.
And then if you just hold up one tab, this is, I guess, more for clinicians. Any shade could look like the color of the tooth. So I always try, and if I'm not using the linear guide, if I'm using my classic guide, it's always always arranged by value. So if I'm looking at, let's say, A2, and I want to go a little brighter, lower, C1, C2, those are all right next door to each other. So I always add at least one or two more when I'm taking my photos. So we've kind of determined 1M1's about our color. We might want to go a hair brighter, so that's kind of up to Peter. But this is where we start. So the first thing I do, I'm a big proponent of rubber dam, and for me, it's just easier to use. Here I've done a split dam, and I don't like the Optrigates. I find them uncomfortable. I had Invisalign myself. I hated that thing in. Cotton rolls don't really do it, especially if the patient has had fillers like we talked about before. If I can't get a retracted photo well, I know cotton rolls and Optrigate's not going to work well either. So why not use a rubber dam? That thing retracts everything for me. It brightens up the whole field, makes it easier for the patient. I can go on and on, but first photo on the left here is my initial preps, and it's a very minimally invasive case. Peter probably would have preferred a little more space, but she didn't really want me touching her teeth. So I kind of showed her, this is what your teeth look like underneath. They're pretty good. If we had a darker prep shade underneath, we may have had to remove a little more, but we're kind of right in the wheelhouse there of 1M1, which is what she was pre. So we're really not moving much, if any, enamel here, just kind of giving Peter a little chamfer so we can get a positive seat on these.
Can I jump in?
Sure.
Because I think this is so important. I've been trying to document this better from a teaching perspective. So you're doing a 2-cord pack.
Mm-hmm.
And even though she's a bio 1, bio 2, she doesn't, she has tissue, but it's not paper thin, right? So she's probably my bio 2.
Mm-hmm.
The point of it is your first cord, I assume, is a triple zero.
Either double or triple. Mm-hmm.
So you're getting in there just to get a little push out of that, and then you're coming back with a second cord. And the reason I'm harnessing this point is I've been kind of working on this from a teaching perspective. One of the things I'm finding, especially with young dentists today, is the concept of cord pack, because everybody is thinking digital, has kind of gone out the window,
Mm-hmm.
right? So whether you're using like Expacil type materials or something to kind of chemically move the tissue and scan, what I'm finding is worse impressions and information than ever before, right? And I think this is such a key point. So that's kind of why I wanted you to show this case. I know it's not like a denture case, but look at the detail that's going into what he's doing. A 2-cord pack, a rubber damming, all the little detail that's going to make this successful right out of the gate. And I think a lot of that is getting skipped over in the digital world. People are kind of thinking, I scan it, I send it, the lab does it, and then I get it back and everything is good. And it's not. It's all these little steps. And again, it doesn't mean you couldn't scan that, right?
Yeah, I could have scanned it.
Right. It could be a scan case, but it's all the work that pre-scan or pre-impression that mattered.
And you can't do good digital without doing good analog.
That's the bottom line.
Important part. So what I do on the left photo is I'll prep to the gingival margin, and then I'll put in that first cord, whether it's a double or triple zero, and then I'll re-prep to that position. That way I ensure that I'm going to be a little subgingival. Then I'll put in my second cord, which is here a 0, and I'll let it sit for 3-4 minutes, and then we'll pull it out, take off the rubber dam, and impress. And I gave Peter a PVS impression here. And then next what I do, so here you can see my second cord is out, and what you can see if you look closely on those preps is there's a lot more room, it looks like, for me to prep. And this is where you can't get into this mistake of prepping even more when you've retracted now double, because you could impinge upon biologic width. So what I'm doing now is I'm making her temporaries, and Peter's given me a very nice wax up and a stent from that, and depending on the amount of time that she's going to be in these temporaries is going to determine how I'm going to make them. I kind of prefer to make them shrink wrapped, especially if I have a lot of tooth structure and I don't really break much contact here. So I have put a little blob of spot etch phosphoric acid, and this is just going to give me a little extra security and insurance so she doesn't come in every 3 days while Peter's making the veneers.
And if it was going to be a longer period of time, you might change that.
And maybe I would use two things a spot etch. So I'll put the spot etch on the tooth. It's all enamel, maybe 15 seconds, rinse it off. And I will also place a dab of adhesive resin on them, light cure it, and then I'll load my Luxatemp Bisacryl into the stent. Shrink wrap it on is the technique, and then I'll take a fine flame carbide or diamond burr, and I'll make sure that I've opened up the cervical embrasures, because right here is the day she came back to me with her provisionals, and I don't know whether it was me under contouring them or keeping them over contoured and not opening them up enough, but her hygiene, not the greatest. They definitely were a little red, so makes the seat a little tougher for me. So these were the provisionals, which were the prototypes for Peter to make the feldspathic.
So he'll send that to me, and I'll just skip right through this. I don't think this is, okay. I've done this a billion times, right? So I have a working model. I'm using refractory dies, an alveolar cast. You can see it's very minimal prep, so I have very little space to work in. I'm going to do a little wash bake, my dentins and enamels. I'm going to start trying to put some effects and work on my contour and shape at this point. And the biggest key is, when I have such a little amount of space to work in, is using the right materials, right? To try to make it look like there's mamelons and things that are there, even though I'm working in 2, 3, 4/10 of a millimeter, right? And at the end, I'm going to etch them and send them back to you. I do pre-etch, so it's normal. And then after trying, your job would be to re-etch for another, I think, 15 seconds?
Yeah, so after trying, what I actually do is I'll just blue etch them, because I know Peter's done.
I've done a 30-second, 9.5.
9.5%. So here's when she comes back. As you can see, the gums, same day, taken from that picture. Now she's numbed up, and I can't just rip these temporaries off because they're bonded in that little circular part. And I need to remember where I bonded them, and I usually keep them in the center of the tooth for that reason. And I've taken a carbide burr and I've reduced my bisacryl here about 1 millimeter or so until I hit where I can see the bonding. And I remove all of that, and once you remove the glue, so to speak, you can pull them off. And I usually warn them that they're going to break off, and that's what happens. So take them off. Provisionals are all done, and here's where I do my try-in. So excuse the gums. It would look a lot better if not, but my first try-in is always just a water try-in. I use a little water, and I check to make sure that the margins are sealed and everything looks good. I don't floss because Peter always gives me perfect contacts. So.
Not always, but I try.
He does. And then at this point is where I'll use a little try-in paste, and I always use neutral, transparent color. And Peter taught me that. He said that's my job to know what's underneath. So if I do my job right, you should be using neutral 95% of the time.
Yeah, we want clears, right? Otherwise, you're affecting the ceramic and the coloration of the tooth, for that matter. And especially in a case like this, where it's so minimally invasive, we want that tooth to come through, because the prep shade was a good prep shade to start with. If the prep shade was black or A7, then we might think differently, or you might have reduced more, right?
Right. Yep. So at this point, now I'll use my transparent try-in paste so they stay in a little better, because they're very fragile. And this is where I'll show her what they look like. We'll do the consent, make sure she understands this is what you're getting. You're going to sign it off. If not, we're going to have to cut them off. There's going to be more fees. So she loved it. And this is where now I will put my rubber dam on. And trying to bond 4 veneers, with gums that look like that is very tricky. So with the rubber dam, it allows me to fully retract everything, and I don't have to worry about much now.
When you see this, I'm curious, because when I see this, what makes me nervous, and I'm not sure how you manage it, so it might be a question for both of you, but I guess more to you. You've sealed your area, which is fabulous from a cleansability point of view and decontamination and all the things that you want. But you've also lost all the things that we worked on, right? Yeah.
Yep.
So when I'm looking at this, I'm thinking, wow, it's so cool how you did that. But I'm also thinking, how do I know that veneer didn't tweak a hair in one direction or another? And do you have a reference to manage that?
Well, good question, because I still have not silinated the teeth yet. So once I have it isolated here, I do another try-in to make sure that they're going to go in perfectly. And if we zoom in on that picture, we can see that they line up absolutely perfectly with the margin. And since I'm using a light cure resin, I only cure until I know that they're exactly where I need them to be.
But I
So
mean,
the answer to your
I'm correct,
question
is you
is
have lost reference.
I have.
But you're confident in the previous try-in and our
Correct.
communication that you're good.
Well,
Yep.
he reseats them. And
I-
if he feels they're seated, then he knows he's there.
Okay.
Yeah,
It
but
makes me more nervous. It makes like more pressure in my brain.
it's
That's why that
true.
better be perfect.
It's nerve-wracking, but this takes a lot of it takes all of the things that could happen and go wrong out at least. The only thing I do have to worry about is getting it seated
That incisal
properly.
edge position back to where
Yeah.
we started.
And once it's like this, I know I'm good. So first step I'll do is I'll air particle abrade with aluminum oxide. I use the AquaCare for that. And then I phosphoric acid etch the two teeth. I do always two at a time, one or two at a time, but always the two centrals together. And the reason I do the two centrals together is to make sure that the rest of the case is going to go smoothly. If I did one at a time and that was a little off, like
Yeah.
you said, that will
Then
throw
you're done
off
for the whole- yeah.
I'm a goner. And then I'll isolate with some Teflon, and then my assistant has now phosphoric acid etched the intaglio of the tooth, silinated, and then I'm going to do a copolymerization since I'm in all enamel and just use a bond on both the tooth, the prep, and the veneer. Load my cement and seat it on. And then I'll cure them together. So I don't pre-cure when I'm in enamel. In dentin, different story. And then I'll put the two teeth in. Next, I'll isolate my lateral. And here I probably etched them both at the same time. But
It's
I
fabulous. It's like you're working in the blind though. It's
You
great.
kind of-
Like
you
it's
kind of
really
are.
interesting to watch because
I like to equate it to if you're getting a gallbladder surgery done, they drape you. They don't know,
yeah,
they
no,
don't know where your heart
it's
is.
a fair point.
Yeah.
Yeah.
So, and here I now have done the lateral. I do one at a time here because I don't like to jump from one side to the next. But if I were doing a canine, I would probably do the lateral and the canine. And here's what it looks like right after they've all been
That's cool.
bonded in. So we don't have a photo. I think we took it out. But if I take that dam off now and stretch it and peel it back, there's just blood and stuff all over, saliva. And this is as clean as it gets. There's no staining.
No, it's fabulous.
So bonded, maybe a week or so later, she comes back in. We take some
Tissue's looking better.
pictures. Tissue always looks wonderful. And there she is. So she knew the limitations. She still has that VME a little bit, but she loves them.
That's
So,
great.
Job well done, Peter.
Yeah, no, thank you. I'm glad, and I'm so happy you guys are here. And if you want to click the next, actually, the Castellano. So your Think Like a Denture case is coming up now, and this is a great case. So if you want to kind of walk us through this a little bit.
So, yeah, I don't know how we're doing on time, so I'll go through it quickly. I know, I think we have both technicians and dentists in the audience.
Yeah.
All right, so very quickly, just to dovetail on some of the things that they said, one of the things that we do with treatment plans, right, is we start with the end in mind, okay? So back in the early 80s, Frank Spear came out with facially generated treatment planning, right? Where do we want the teeth in the face? Okay, and this is what Peter started the lecture with this morning about when you're making a denture, where is that incisal edge position? He incorporated into facially generated treatment planning the EFSB concept, which is aesthetics, function, structure, and biology. Now, aesthetics is first for a reason. Because if you don't incorporate it first in your treatment plan, you'll lose it at the end and you won't be able to get it back. So treatment planning should be done in that sequence: aesthetics, function, structure, and biology, but not treatment. If someone has periapical pathology on number 8, you're not going to do the case and then do the root canal. So it's important to distinguish between setting up the case and treating the case. And now for those of you familiar with Spear's work, they have now changed the metric, and now the model is AEFSB, and the A being airway. And airway has to be first considered for a number of reasons, and we won't go into OSA and things like that. So with Nina's case, she had a oligodontia. Okay, for you lab technicians, that is a congenital disorder where you're missing 6 or more primary or permanent teeth or a combination. And so when she first came to me, she was a deciduous patient. And so what Dr. Avendolio and Peter have been talking about is incisal edge position. That's very, very important. There was another thing that we needed to consider in her case, and it was proportions. She had baby teeth. Her canines and her laterals in the maxilla were deciduous. She did not have succedaneous teeth. So if I was to impress that and give that to Peter and ask him for a wax up, he's already working on teeth that are the wrong proportions. And so we had an arrangement issue here. Her teeth were in the wrong place, but if I sent her to ortho and he fixed the arrangement and leveled everything, what is he doing? Well, what's the width of a deciduous lateral incisor? It's about 5 millimeters. And deciduous canine is 7 at best. And so what's the width of a permanent lateral incisor? At least 7 millimeters, probably more. And a canine, 8 millimeters. So if the orthodontist is working with teeth that are not proportioned properly, he has a real issue with arranging them, because he's going to bring the teeth close together. And then when I have to eventually restore implants, we're not going to have enough room.
Can I throw something interesting in here, if you don't mind me cutting into you? I've done a bunch of cases like this over the years, and one of the things we do to manage the orthodontics is, if you sent me her case, if they weren't deciduous teeth, she's got deciduous teeth, so it's a different world. But let's say the teeth were just all malaligned. What we would actually do is follow the root form and wax the tooth from an ideal root form position, which means when you put it in the mouth, her lateral might be sticking out in left field. And the goal of that is now to send her to the orthodontist and make him or her put the root in the right position, right? So it's kind of,
right,
we're guiding it kind of the way you're going to get to, but just from a wax up perspective.
Right. And so the way we did it was I did a crown on her front tooth, I believe it's 9, and a veneer on 8. Those are permanent teeth. And then I did prepless veneers on the other deciduous teeth, so the laterals and the canines back. And so then by doing that, and I explained to the parents, listen, we're going to have to do veneers on these teeth that are eventually going to have to be extracted. So once we did that, we got the proportions of the teeth the way we wanted them. And then we sent her for ortho, and then the orthodontist arranged everything based on what the final restorations of the permanent case was going to be. So then she went to ortho, and then she came back. After everything was arranged, we still had an issue. She's brachycephalic. She does not show a lot of teeth. She shows absolutely no soft tissue, and she had a deficient maxilla. So we initially treatment planned her for orthognathic surgery to do a maxillary advancement and a tipping. And also both arches, we're going to have orthognathic surgery. We're going to reposition the arches, rotate them clockwise, and also do interpositional grafting and plating. The parents weren't in favor of that, nor was she. And so that presents a challenge now. Now I have to talk to Peter about, look, this is what we have. How are we going to compensate for the deficits that she has? We need to show more teeth because she does not have a very high lip line. So Peter and I began the case. We took impressions. Peter gave me a beautiful wax up. I carried the wax up into the mouth. We're using bisacryl like Dr. Avendolio talked about. And just to sort of get an idea of the incisal edge position, the occlusal plane, the teeth moving apically as they move posteriorly to get those cusp tips where we want them. Then from that, I made her a surgical matrix. And I sent that stent to the oral surgeon. He brought it to the OR and he placed the implant. Now, this is a great example of, and this is certainly by no means being derisive, but no matter how much information you give a specialist, sometimes the implants don't come out where we want them. Okay.
Even if you design them digitally.
Even if you design them digitally, right? There is no panacea.
Yeah.
And so, this speaks to the audience today. The communication between you as a lab technician and you as a treating dentist has got to be fulsome. And if it is, what typically happens is you'll rarely speak to one another because you will have worked out everything in the beginning and then the case just flows. The last thing a dentist wants is a call from the technician and vice versa. And so, okay, so I'll go very quickly through this. Okay, so we prepped the teeth, and then we had a bit of a challenge. I did not want to do anything cement retained for these, and so I asked Peter to work his magic, and he was able to make all of the implant supported restorations that should have been cement retained. We couldn't even use an angulated screw channel. And so do we have the occlusal shot of it,
Yeah, I think
Peter?
there is one there.
Okay, so this is the final case. Let me see if we have the
There it
occlusal.
is.
So you can see the set screws here that Peter was able to put in the back of these crowns, which should have been cemented. And so because he was able to do a set screw design, we were able to keep her out of any cement. So that's the final case.
Typical ceramic stuff, a little fluorescence in there, right?
Just beautiful work on Peter's part,
That was
and
good
just
teamwork.
makes us look good.
And the best part, I think if you go one more, you'll have Nina there herself. So that's one of my favorite shots. And then one more, Nina kind of sums it up for us pretty well if you just click it. Okay. So Nina, how does it feel to be done after all this time?
Amazing. I look in the mirror every day and I smile just thinking about how amazing this whole thing has been now that I'm done.
And you worked with a great doctor, right? So Dr. Castellano was so helpful, I'm sure.
Yes, Dr. Castellano was the best. He treated me as if I was one of his family members, and just the care from everybody and this whole team has been incredible.
How about your comfort level now that I know before we had missing some teeth and there was some deciduous baby teeth there, kind of?
I grew up just kind of smiling with my mouth closed, and I always caught myself in the middle of laughing with a big mouth and just reminding myself, just keep your mouth closed. And now I'm just carefree, and I feel so confident whenever I talk, smile, laugh, eat, whenever I'm with anybody, go out to dinner. I don't have to worry about anything.
Well, they look beautiful and they work great in your face, so thank you. And I would say that's what really is the key for us, right? I mean, think about, thank you guys for being here, but the key really is that, right? Everything that we do together is for Nina or is for your patient or that patient. It's always the same. We're all thinking about that the whole way through. And that's the rewarding part, right? When we see that we made them happy. And we could probably analyze it. I know you and I analyze our cases. We analyze every little detail and we want to change and fix and a hair more of this and a dot of that. But in the end, that's for us, right? That's retracted us critiquing ourselves, dentistry, where the patient leaves and feels like happy and successful at what they did. So, Jim, I think we're a minute or two over, but hopefully we're okay based on the fact that we got cut out.
Yeah, no problem at all. Thank you very much, everyone. Do you have time for a couple questions or no?
Yeah, sure.
Okay, so thank you very much. Just a couple of questions. A couple of cases you showed you had a upper and lower. You were doing both. Do you start have a preference on? Do you start with maxilla or the mandible? Is there a
always the maxilla? Not even a question.
Preference.
Not a question. Always the maxilla.
Okay. To summarize, how do you how do you decide how much of the gum tissue to cover by overlapping with your denture?
That was our conversation last night. Well, why don't you give that answer?
Well, no, so what I think Peter and I are more in agreement than he
Yeah, we
would
just like to
allude to,
banter.
but yes. So essentially, the margin between your acrylic and the native soft tissue, if it's hidden, okay, then you don't need to extend it as long as that lip covers it with a full Duchenne smile. When it isn't, when you have somebody with VME or somebody with high lip mobility, and you can see that margin, then the flange needs to be extended. So that's a basic rule of thumb. Then in addition to that, Peter showed it, quite aptly on Bernadette's case, there was lip support that was needed also. So that elderly patient didn't show the margin between the acrylic and the soft tissue, but he needed some lip support. So Peter then, called an audible and extended the flange higher.
And the third factor is hygiene, right? So once we get to the point where we're covering the tissue, what's the hygienic parameter, and can it truly be fixed, or is it a removable fix, fixed detachable, depending on how you want to classify it?
Right, and by that,
thank you.
Just to finish that point, if the flange needs to be extended, let's say very close to the vestibule, there's no way to clean around the platforms of the implants, those connections. So a fixed detachable or a hybrid is typically, in dental parlance, something that only we remove. And so that happens annually, maybe. And so the patient can't maintain that. So what Peter showed, that case with the MK1, is there's a wrench that's given to the patient where they just pop out these pins and they can detach the hybrid and then clean it. And so it's important to understand that if it's a hygienic concern, then you're going to have to make something that the patient can take off and maintain.
And the third or the fourth, snuffle in there is the patient's manual dexterity to do that.
Right.
So that might not be the option for them.
Or they would need help.
Or a different type of attachment, depending on,
one of the questions was on where you spot bonded your temporaries, your provisionals. How large of bonding area is that? Like 2 millimeters, 3 millimeters? What kind of
exactly how much frost's over once I rinse the etch. So it'll tell me exactly where I need to add the bond to. If I covered the whole tooth, I would never get them off. I'd have to cover.
No, he's saying how much is the size of the dot you're putting.
Oh yeah, like
diameter.
2 millimeters. Yeah,
Yeah,
2
okay,
millimeters.
very small.
Yeah, pretty small.
I think the common sense of it is the larger you make it,
The harder it is,
the harder it is to remove later, right? So you got to kind of balance that out. And by the way, we communicate that, meaning he has a veneer case coming up. I usually know when he's prepping it, and I'm scheduling 2-3 weeks at the max to kind of make that work. And if there's a reason I can't, because I'm here or somewhere else, he might change that spot edge. And that's kind of an important process to be on a communication level with.
Yep. I always know the prep date. I know Peter's make date, and then I know my seat date. And he knows the same thing from me. So we coordinate it.
All right. Well, I know we're running on time. You guys got to get going. So I want to thank everybody for joining us. Any last comments, Peter and doctors? You want to anything?
I would just, it was fun. So thank you. I threw this at these guys kind of late last night. And I have to say, it's so much fun. I think I enjoy doing these with teammates, especially ones that I enjoy being with. It makes it so much more fun. And I hope the people who are watching enjoy the change that we try to add these in a little bit more often, because it's so nice to get it from a clinical and teamwork perspective.
Definitely. Yeah, appreciate it. So taking time out of your day to do this. So, but again, thank you. Thank you everyone for joining us today. And you guys have a wonderful day and conference where you're at. So, and we will talk to you soon.
Thank you, Jim.
This will end today's webinar. Thank you.
Take care, everybody.